Introduction to Nursing Concepts, Laboratory Values, Part 2. This is Martha Olson. Finishing our electrolytes, we look at that chloride level. It usually follows along with the sodium. Very rarely do we see a hyper or hypochloremia by itself, but hyper again would be the above the 105 milliequivalents per liter, and hypochloremia is below 95. When we look at a patient with diarrhea, perhaps that patient would be losing a lot of their electrolytes from the diarrhea stools, and we would be very concerned, especially about the very young. The infants and the elderly oftentimes get admitted when they have a bout of the flu with diarrhea. They're very dehydrated because of the loss of that potassium. As the part 1 lab value stated, it can affect the heart rhythm, and somebody with a very low potassium level can have a lot of arrhythmias, as well as when it's hyperkalemia, can have problems as well. So we watch patients that have fluid and electrolyte changes very carefully because of the serious consequences that the electrolytes play in the body, and with lack of those, we can see that in our patients. As far as the nutrition unit, we'll be looking at our fasting blood sugar and what we call glycosylated hemoglobin, or oftentimes referred to as an A1C. Your fasting blood sugar has been lowered. It's down to 70 to 105 for normals when you haven't eaten for several hours. Your glycosylated hemoglobin, you don't have to take fasting, and that just tells you the average blood sugar for the last 3 months. Our patient with diabetes, then, oftentimes we will get a fasting blood sugar if we believe that the patient is hypoglycemic. That's the one where their skin is cold and clammy, needs some candy. Or if they're hyperglycemic, the skin is very dry, and they will be exhibiting problems based on their blood sugar, and we would want to check a fasting blood sugar immediately and then know what action to take based on that. Many of your facilities will have standing orders that if your patient is hypoglycemic and very cold and clammy and unresponsive, you're going to give IV dextrose, that sugar in the vein, to get them back up to where they need to be and correct the problem. Your glycosylated hemoglobin just helps the doctor identify this is not a new blood sugar problem. The average red blood cell lifespan is 120 days, and so it looks at the red blood cell and says, for the last 3 months, this is what your average blood sugar. You want a lower number. 4 to 5% is ideal. Many of your long-term chronic diabetics that are not well controlled might have a blood or a A1C of 10%. And with each percent that it comes down, it tells about better blood sugar control that person has had. In our tissue unit, we specifically want to look at a protein called albumin, and it's about the same numbers as your potassium, 3.5 to 5. It's a protein that makes up muscles, enzymes, hormones. If you remember from the protein unit in nutrition, we talked quite a bit about why you need proteins. Well, this specific protein called albumin is oftentimes low in your patient that's had burns, had major trauma. It has a lifespan of 12 to 18 days, so it's not something that just simply happened. We think about this with our patients that have liver problems, because this protein albumin is made in the liver, and with any kind of liver failure, you might have problems with albumin. Many of your little old ladies and gentlemen that come in and they have a lot of edema, we check albumin levels, looking at the fact that maybe they don't eat meat or eat any source of protein. Maybe it could be a malnutrition type of problem that they have going on. But for this intro class, I think about it with our burn patients, because they need more albumin, that protein, to help heal the tissues. And again, I'm pulling information from the nutrition that you have had as a pre-nursing student or last semester, to know that protein heals our injuries, and your patient with surgical wounds or the burn patient would need more of that albumin. And we look at that lab value to help us determine, do we need to maybe consider total parenteral nutrition or changing in the diet or supplement, something else to add to that. Our elimination unit is going to look at our urinary system, specifically our BUN or blood urea nitrogen and our creatinine. Creatinine is more indicative of the kidney function because it's not affected as much by hydration status. When you look at a patient that is admitted to the hospital, maybe they haven't had anything to eat or drink for a couple of days, they've been very sick, their creatinine should be an indicator of the kidney function. The BUN is going to be affected by the fact that they're dehydrated, and it may be extremely high looking until you get them back to hydration with an IV. So your BUN normals are 10 to 20, and it should be a 1 to 10 ratio with your creatinine. Creatinine is a smaller number, 0.5 to 1.1 milligrams per 100 milliliters, and we're just looking at how well the kidneys are working. And when we think about all of the patients that have kidney failure, when we start looking at pharmacology and medications that become toxic because the kidneys don't work, your BUN and creatinine are very often done on almost every patient just to see the effects of the kidney and if they are working or how well they are working. So we look at renal function test, your BUN and creatinine, to tell about how the kidneys are able to eliminate the toxins and how the liver is able to metabolize and help the body to get rid of things. When the kidneys do not work to filter the waste products, oftentimes your patients with chronic renal failure will go on dialysis 3 times a week, or we will look at what are some medications that we can give them, like a diuretic, to help eliminate some of that extra fluid from the body, because we can't have the toxins going around in the body causing a lot of damage, or soon it will be a whole systemic failure for the patient. In the mobility unit, I always think of the SED rate or ESR, which kind of tells us about inflammation. When you have somebody with a lot of arthritic problems, usually their SED rate is elevated. Normal is 15 to 20 millimeters an hour, and it just is looking at the red blood cells that settle in saline or plasma over time, and those red blood cells then stack upon each other and get heavier and heavier, causing them to descend faster, and that's why it's measured in millimeters per hour. So it's just looking at the red blood cells and tells us about things like inflammation, acute and chronic, problems with necrosis and infarction that might increase that. So your patient with arthritis, we might see increases in your SED rate if they have any renal failure, some of your inflammatory diseases, but we don't usually use the SED rate as much to diagnose, but just more to see, is the therapy or is the treatment we're doing helping them? So in conclusion, with our lab values, these are the sources that were used, and just start thinking about using your Paganda book as we work on case studies. Bring it and study it, thinking about, what are we going to look for as we do the scenarios in classes. That's the end of lab values. I hope this was helpful. Have a great day.